Welcome to Eating Disorder Treatment Facilitator, development of a concept from an IDEF task force. I'm Marie Grover, and I'm the Director of Events and Continuing Education Services with IDEF. Before we begin, I want to cover a couple of important housekeeping items. At the bottom of your screen are multiple application engagement tools you can use. All of these engagement tools are resizable and movable, so feel free to move them around to get the most out of your desktop space. In the resources area, you will find a session information and disclosures document. This document will provide the CE information for this session, including how many CEs are awarded. We have a new process for earning CEs this year. On your screen, you will see a widget titled Quizzes and Evaluations. Here you will find a link to Context. If you wish to earn CEs for the session, you must pass the quiz, complete a session evaluation, and finally complete the overall event evaluation within the Context platform. We are pleased to have Karen Samuels, Catherine Fink-Martinez, and Therese Waterhouse with us today. Karen Samuels, PhD, psychologist, is the founder of COPE, Community Outreach to Prevent Eating Disorders, and served as the resident psychologist and body image specialist. She promoted size acceptance and diversity on wellness platform 108.com. Utilizing relational cultural theory, she trains physicians, offers school and community outreach, and eating disorder groups with midlife women. She has published widely, highlighting eating disorders and related health concerns in midlife and beyond. Dr. Samuels was awarded the 2014 Nita Weston Family Award for Activism and Advocacy. Catherine is the owner of Confidence in Eating and a CEDRD supervisor. She is a certified intuitive eating counselor and has published on bariatrics and adverse childhood experiences. She speaks nationally and works with clients and professionals through individual work and courses, teaching them how to dissect food challenges in the nutrition care of emotional eating with a specialty in binge eating and post-bariatric complications. Catherine has served numerous roles in the eating disorder and behavioral health community while also working as a nutrition professor and fitness professional. Her motto reflects the belief in a balanced approach. There's always room for ice cream and chocolate. Therese S. Waterhouse, PhD, RDN, CEDRDS, FAED, is the owner of Williamette Nutrition Source, LLC. Therese co-authored the ADA practice paper on nutrition intervention and treatment of eating disorders and has served as credentialing chair for the Oregon IDEF chapter, director of the Eating Disorders Subunit for SCAN, and is co-chair of the Family-Based Treatment SIG within the Academy of Eating Disorders. She served on the Medical Care Standards Committee for the AED and co-authored the AED Nutrition Guidelines. Therese has been actively involved in training medical and mental health providers, offering an elective rotation to fourth-year psychiatry residents through Samaritan Regional Health Services, development of a training program financed by a grant from the Inter-Community Health Network, and currently developing a community-wide eating disorder training program with Douglas County and Umpqua Health Alliance in Oregon. With that, I will hand it over to our presenters.
Welcome. We are so excited to present to you today what we've been working on. There have been considerable effort, research, time, and collaboration to bring the EDTF model to deliver to the audience today. So I want to share our mission statement and excited for you to learn about what we've been working on everyone's behalf in this field, and hopeful for the promise for the future. This task force was developed to assist primary care medical providers, PCPs, with a system of experienced eating disorders professionals as a resource to facilitate the treatment of their patients with eating disorders. Knowing that most of our eating disorder patients enter the healthcare system with their primary care professional first, and that many of those PCPs, those professionals, do not have an experienced colleague to turn to for advice, we believe that the EDTF initiative can and will serve an important role in our fight against eating disorders. Thank you.
Hi, this is Therese Waterhouse, and really I think what we're doing today is telling a story. We will all start with the recognition that all of us that are specialists in eating disorders have recognized the persistent problem that frontline medical providers, PCPs frequently miss eating disorders diagnoses, or if they make the diagnosis, they're unsure of what to do next. What are the next steps? Many of us have been involved in attempts to address this issue through numerous hundreds of excellent training initiatives. The AED, Eating Disorders Critical Points for Early Recognition and Medical Risk Management in the Care of Individuals with Eating Disorders, fondly referred to as the AED Medical Purple Booklet, was a wonderful effort and attempt, and it still is a fabulous resource for so many of us. We had hoped that this would really reach pay dirt, that it would reach the PCPs. However, a lot of us have heard PCPs don't have time to delve into all of those critical points in that booklet. I and hundreds of others have developed training efforts. I'll talk briefly about the grant work that my company did to train providers, healthcare providers across 3 counties in Oregon. And then we have the current big effort from NCED, Eating Disorders in Primary Care. They've developed a novel tool, the Spirit ED for screening and referral, specifically aimed towards PCPs. Again, lots of good efforts have gone into trying to reach those frontline medical providers, but we don't always see the results that we hope for. Next, Catherine will talk about sort of our timeline.
So my role here is just really going to be talking about what we have done within the committee and how it has progressed within IDEP. So we did have Williamette Nutrition Services brought the grant and an outcome survey to us in 2016 and 2017 with the idea of let's do something more with what she had seen. The IDEP did a non-eating disorder professional survey to basically solidify, is this something that's needed? We did a pilot survey to eating disorder professionals, and then we also did a IRB survey for eating disorder professionals, and that was in 2019, 2020. So we'll be presenting a lot of that information throughout this talk. Therese?
So let's talk about where the eating disorder treatment facilitator concept came. So Karen and Catherine and I have already discussed the fact that we greatly appreciate all the training efforts that have been aimed toward frontline medical providers. I also I was awarded a grant in 2016, 2017 from the Intercommunity Health Network Coordinated Care Organization, which is our local Medicare arm spanning 3 counties. Mainly rural. Eating disorder resources are very sparse. And so the purpose of the grant was to train non-eating disorder specialists in some basic skills, help relieve some of the ignorance around eating disorders, give people some basic tools so they could early screen and recognize eating disorders. And we really were hoping to reach these underserved areas. So, and what happened? So the goals of the grant, like I said, were to train healthcare providers, medical providers, nurses, dietitians, therapists in screening, recognition, evaluation, referral, and treatment, and to give them some tools to use if they suspect or diagnose an eating disorder. Here are some of the training outcomes. I'm not going to belabor all of this. We did have some good outcomes, but I want to draw your attention to this last unexpected outcome. Most of the PCPs, the medical doctors, and these were all people who I knew most of them. They had interest in gaining education about eating disorders. That was one of the criteria for entering into this training program, which spanned a whole year. You had to have interest in learning more. So what I didn't expect to see is that most of the medical doctors dropped out of the training. reporting lack of time and lack of support for doing anything extra. That was a problem. So I really felt the need to delve into and to talk to doctors. I was able to meet with lots of different groups. I met with all the directors of internal medicine. I met with gastroenterology groups. I met with all the doctors, both individually and via survey that were in the training I initiated. And I just said, so for example, this was a exit survey question for the doctors that took the training. What barriers kept you from using the online learning modules? Or what barriers kept you from participating fully in the training? And this is what they said. I don't know if you can read this, but lack of time was first. Lack of institutional support came up also, not surprisingly. And so this is just, you saw the bar graph. This is the written results, lack of time for doing anything extra. And so I kept thinking, I've heard the same story from so many hundreds, literally, of my colleagues over the past 20 years. They've initiated these fantastic training efforts trying to reach frontline PCPs. Somehow, we're not getting the results we hope for. So all of a sudden I said, well, you know what? Maybe we need to do something different. I really kind of leaned into listening to the PCPs, and I developed a lot of compassion for them in their position. A lot of them have quotas where they have to see 45, 50 patients per day, which seems unimaginable to me. And then at the same time, I said, a lot of the PCPs really lean on therapists and dietitians for help. So I started thinking, do we really need the PCPs to do something different? Or do we need them to recognize that they can ask for help? So this really, I spent a lot of time thinking about this and thinking about, when we train PCPs, what do we expect them to do differently? And some of them in exit surveys said, I'm really not sure what to do with the training. I don't have time to do more work in my practice. And a few of them actually said, I just call you, Therese, because you're an eating disorder specialist. And guess what? At various conferences, and I've heard, and I'm sure all of you are nodding your heads, you help PCPs out quite a bit. So the hypothesis was developed that this work of an eating disorder treatment facilitator is in fact being done. It's just not recognized. Further, it's not compensated. So, this really got us thinking. So I decided to name this unrecognized work and name the entity. And I came up with initially Eating Disorder Health Navigator, which we later changed, and you'll hear why. And I asked in the exit surveys, how helpful to your practice would it be to have an eating disorder health navigator or a professional that you could contact locally to discuss a patient with an eating disorder? And the eating disorder health navigator is defined as the go-to person in your community for eating disorder related questions, education, which includes, the education includes information about signs, symptoms, diagnostic criteria of eating disorders, labs to order, hospitalization criteria, treatment and counseling recommendations, inpatient, outpatient treatment resources, coordinating communication within a multidisciplinary team. And so all of this on this slide is what I thought eating disorder health navigators provide, and what actually I've heard from so many colleagues over the years that they do this type of work. So here's the results of some exit survey questions. How helpful would an eating disorder health navigator be to your practice? Very helpful was the response from close to 96% of those asked. So the concept of an eating disorder health navigator was given to PCPs as part of the grant exit survey, which I just showed you. I also did interviews with different groups, as I said, and most PCPs said, absolutely, I would love something like that. In fact, I have something like that. Either we call you or we call one of the other eating disorder specialists that we happen to have a good relationship with. And I know both Catherine and Karen, who are doing this talk here, they do this work too. So again, I'm not going to belabor all of the outcomes of the grant, except I like to highlight this unexpected outcome that once again, we saw PCPs telling us quite clearly that they couldn't absorb all this training, they don't have time, and clearly they're asking for help. So I thought, maybe this is a good idea, Eating Disorder Health Navigator. I'm just one person. I own a small private practice. I can't do this by myself. So I thought to go to both the Academy for Eating Disorders and also IADEP and say, please help. Let's all join forces and put some teeth into this. Let's recognize the fact that this work is actually being done. It's just not recognized nor compensated, nor do doctors have permission often or feel like they should reach out to somebody. Some physicians are in communities where they're not sure who to reach out to or if there is an entity like an Eating Disorder Health Navigator. So IADEP has really picked up a lot of the lion's share of development of this and put some meat into it, which you will hear both Karen and Catherine describe coming up.
So back to when Therese brought this to IDA. So she brought her information to the committee at the time. That was the Nutrition Health Management Committee. And we brought this to the board and said, hey, this is something that we're interested in looking at, because we all shared the same information and said, absolutely, this is something that we need more of. And so we took Therese's work and basically advanced what she had done and just added to it and put out a survey from the board in January 2018. And this was to non-eating disorder clinicians. We wanted to make sure that this was something that they needed. The board wanted a further follow-up to what Therese had done. So we sent the survey out to mostly physician groups. And again, this was non-eating disorder clinicians, and asked them, do they recognize that they encounter patients with eating disorders in their practice? And you see with the bar graph, overwhelmingly yes. And with the breakdown here, you see 93%. It was 120 participants that did that, said 93% yes. And the next survey then became, would an eating disorder health navigator or professional in your community whom you could contact to discuss a patient with an eating disorder be helpful to your practice? And you'll notice this is basically information that we just added on and used with Therese, and you'll also see some similar outcomes from our surveys. Again, very high reporting that yes, it would be helpful, with the breakdown at 93%. Then we looked at non-eating disorder survey question of, if you encounter, are you comfortable in treating them, or do you have resources available that can help you? And we have about 50, actually what ended up happening with this, it was about a 50-50 kind of split. And here's a little summary.
Hi, I'm Dr. Burkus, and I just want to talk to all of you primary care docs, because don't mind them. They just found out that you have access to an eating disorder treatment facilitator. So you don't have to worry if you have a patient with an eating disorder that's taking too much time and you need help. So call us and we'll get someone to help you.
So that was an example of kind of some of the challenges from non-eating disorder professionals who and physicians who like time, don't know what to do. And that's actually one of the videos that we're building. We're building some resources as part of our marketing aim to kind of get out there. So Dr. Vicki Burkus did that for us just to show how it would be helpful, because indeed they do say that some of them have resources and somebody to go to, and some of them don't. So more so, yes, kind of a 50-50% on with the highest being yes, they have them and they have some resources, and 48% kind of no. The fourth question, non-eating disorder, how much specialized training do you have about eating disorder? And you see a very high amount is only briefly in medical or graduate school. And we break this down a little bit further with the graphs as to none in the smallest percent, and then just the briefly medical school at the 39%, and then some continuing education, and then other. And on the other, it was the answers typically were a combination of things, or have they've done training and they've done medical school, or there's some supervision. So the others were basically a combination of what we already had in the survey. Then question 5, what's your level of familiarity, both professionally and personally, because we thought they might be maybe not have enough or a lot of training professionally, but they might have some personal experience with it. And with the survey, we do see a variety, with mostly saying they've previously treated with eating disorders, or at least a large percent of it. And we break that down into some of them had an eating disorder, some of them with family members at 27%. Some have had advanced training at 28%. We didn't define exactly what that advanced training was, but again, this is the survey just to see if the interest is there and kind of validate it. Question 6, what's your professional license and registration? Again, our target was primary care providers, and you see that the highest amount was physicians, psychiatrists, and then the smaller amounts we had PAs, nurses, some dietitians, psychotherapists, and it breaks that number down here with 57 being physicians and 17 kind of being the PA. So our target really of getting these, and this is all non-eating disorder clinicians. So not just, but targeted at the primary care level. So taking this time development, the board looked at the results and like, absolutely, we're solid behind the project. Let's go on ahead and go forth. And with Therese's interest in wanting to really not just be IDA, but have this be a big collaborative. It's not any particular group that's doing it, but the idea of the more that we get to do this, the better we can reach providers. So she reached out to the Medical Standards Committee of the Academy of Eating Disorders, and they were willing to provide some help in just the development and input from it. Now, this is also a time when we looked at a name change, and basically we discovered that NEDA, the National Eating Disorder Association, has a navigator. While this is a different entity, the concept still, we believed, would provide some confusion, because their entity is more with families and peers who had kind of been through an eating disorder versus professionals. So this is when we changed the name to decrease the confusion. In 2018, we launched our pilot survey to find out a little bit more about what it is, people who are out there acting in this role, what do you do? So we could have that evidence as we build the program. And in January 2019 is when we had the Academy of Eating Disorders director at the time join us and provide input along the way also of this concept. So continuing to be a group effort. So here we have our pilot survey results. And the purpose of the survey was to test the hypothesis that healthcare providers are already doing this. We had 170 in this survey. And we're not going to go through each survey, but we're going to just pick a couple of key points, because the pilot survey and the IRB had similar results, with the key differences being in question 1, do you frequently do work outside of what would be considered usual work within your professions? In the pilot survey, there was 87.6%, and in the IRB, it was 70.4%. And then question 8, which profession more closely matches your work. In the pilot survey, we had more dietitians than we had therapists, psychologists, so it's like 67% versus 27%. And in the IRB, we had dietitians being the lower amount at 31%, with psychologists being the higher amount. And I think that is the reason that the questions are a little bit differently, just because of the type of work that dietitians typically do versus therapists with collaboration and team members and treatment. So here's from the pilot survey, the question 1, do you frequently do work? Another overwhelming yes, and we have the numbers broken down as we have here the 87%. That's 149 people who did say yes, they do the work. And then our next question, in looking at the time development, this is when we turned and formed the Eating Disorder Facilitator Collaborative Task Force name and took the information from our pilot survey and went, because we wanted to make sure that we could use this research and that, we could actually do the right thing as to developing the research and our outcomes. So Susan Julie Hash submitted the survey to the University of Michigan IRB, and we received an IRB approved exemption. So we do refer to this as the IRB survey because we went and we put it before the board, and we were given the exemption with the survey in January of 2020. And also in that year is when Therese and Susan Julie Hash did a grant and initial IDEP summary work. They presented this at the International Eating Disorder Conference presentation, continuing really just to get the word out to let people know what we're doing and what we're finding. Which brings us to what that survey, which was launched in January 2020, we sent this out to outpatient eating disorder professionals. We had 689 participants with this survey. We sent it out through the IDEP membership. We sent information out targeting getting to AED members and working to try to get eating disorder professionals to fill out the survey. And so our results, outpatient survey, is do you frequently do the work that might be considered usual outside of work within your profession? And another, you see similar results. Yes is a large amount, and that was at 70%, 485 participants. Question 2, we wanted to know what types of tasks do you perform that you see as necessary in order to keep outpatient treatment optimal? And this is based on, when we said necessary, based on evidence, achieving timely results, provider communication occurring regularly, and they were to check all that applied. And you will see a mix of responses and results. And we're going to break that down for you individually and highlight the key ones. So the biggest ones and the responses that we got were educating other providers about eating disorders at 89%, educating families about levels of care and eating disorder treatment, getting a person to the appropriate level of care and informing treatment members of this and calling treatment centers and helping to get the initial intakes done, as well as challenged to the overuse and the limitations of the BMI as diagnostic tools in eating disorders and treatment. So a lot of education about, if somebody is not considered underweight, still an eating disorder, and that how the BMI can be a challenge. We also wanted to know what non-compensated tasks that you were doing. And so another variable where you see that there were some tasks that stood out as being higher amounts. And we'll go over that just after our video.
I have a patient right now that is post-bariatric surgery and is having lots of complications, one of which is she has an eating disorder. The problem is she is seeing all of these specialists, but nobody who has an understanding of eating disorders. As a clinician and an eating disorder expert, I have the resources and the ability to help all of these treatment providers, many of which are physicians. And so a perfect example of how I'm doing that is by my summary notes that I'm sending out to the treatment teams to give an indication of some things that they might want to consider. So while I don't diagnose, I can and do provide information to help them think about some additional things. This particular patient has had a bariatric revision because of an ulcer and several different complications. She's lost a tremendous amount of weight, very malnourished, and only recently opened up to me and her therapist about purposely restricting. And also just recently got put on a feeding tube, was having some complications, and actually had large amount of swelling and edema that happened very, very quickly and was sent to the ER. I provided information about the potential for refeeding syndrome, which is very much a big concern for this patient, and there wasn't any awareness. So an EDTF type of person is something that I'm already doing. I'm kind of acting and being a resource and giving some information to the providers who aren't really sure of some of the things that can cause some problems. And so I also am the person on the team that the physicians, the dietitians, and this particular patient has several dietitians, look to. So this patient has a nutrition support dietitian who doesn't really understand eating disorders. She has a bariatric dietitian who doesn't really understand eating disorders. And then luckily she has me. So just a little snippet of information of how somebody is already acting in this role and is of assistance. It could be even better if we could reach out and give these physicians ahead of time where they knew if they suspect there's an eating disorder, they have somebody that they can call to help them with some of these questions and concerns.
So that was an example of a way an eating disorder treatment facilitator can act. And most of you understand this and do this work. There's also some of these examples of what we don't think of as often. That particular client, it was sending just all of the information to say, the patient appears to meet criteria for this eating disorder, and giving them all the helpful information. It would be nice if others kind of had that or could reach out and kind of, if they suspected some of it. So back to looking at the non-compensated tasks, phone calls with other providers, family members, look at the 89%, 82%, phone calls with higher levels of care, referrals to treatment programs, providers, networks, and then, along with that, the getting pre-authorization, assessing labs, talking to insurance companies, organizing education materials. So a lot of stuff that we do to help get information out to those who need it. Non-compensated, of course. Team member experience. We wanted to know when you have somebody who doesn't have experience with eating disorders, what sort of things do you do? And same kind of results as in sending research. Big one, education on the phone. 70% acting as a team lead, helping to inform team members of what needs to happen next in the care and giving kind of options. It's always back to the physician and the primary care. And we all talked a tremendous amount of time in our committee meetings of how it's still the primary care physician is still the primary provider. We are there as a resource, and we can help them to see some other things and educate, but it's still the physician is the one that is in charge, and just being a resource to help get that information. And at the bottom, when it talks about the other was a combination of things that was being done. So like some of them support groups that were done, free support groups for family members and for the individual. And really just a combination of kind of what we already had in the survey of results. Patient assistance and kind of non-billable. We wanted to know how much time did you spend doing this? And so when we looked at the hours on average per week, you see the highest was 2 to 5 hours per week, with a range from 0 to 1 hour to greater than 10 hours per week with helping patients in non-billable time. And here you have the results broken down. So that 2 to 5 hours, 38.6%, and that was 266 people. So a lot of time, you know it. We spend a lot of time outside of the time that we are with clients working on collaboration. And then we looked at years of experience and how many years they had working with eating disorder professionals. And we had a variety of responses, with the smallest one being 1 year and the greatest being more than 11 years at 45%, or 314 in the survey. And here you have it broken down, just looking at it visually. Treatment setting, because remember, our target was private practice and primary care providers. Our results did get that we were at 70%. The others that were in the treatment settings that they worked in was partial hospitalization, inpatient or residential, a little bit on academic, and some eating disorder associations or nonprofits. And here we have that broken down by percents at 74%, or 510 that were in private practice. And then we wanted to show the profession that filled it out. And the highest here was the psychologist, therapist, and social worker, and dietitians. We did have physicians and psychiatrists. And when we get to the other, it was a combination. So when it was the other, it was a combination of a dietitian who's also a PA, or it was a therapist and a dietitian. So people who served dual roles. But primarily here, we were 55% psychologist, therapist, and social worker. And then here, I'm going to hand it over to Karen to recap where we are with the committee and what we're doing.
So, as you've heard, we have quite compelling evidence, numerous from Therese's initial grant that really got the ball rolling and took the form of getting this progression to the IRB study with considerable numbers and data. We're not sure who our audience is who will be watching this, but I think we all collectively imagine that you've been nodding right along, that this is telling you the obvious, what you already know and what you already do, that we're doing this work. So part of, I believe, if you go back to the mission statement, our intention is to name it, that the power of naming, that the eating disorder treatment facilitator is you. And it's work that you're already doing, but it's invisible work that has been unrecognized. And we firmly believe that, like the original work that Therese brought to all of us, that our primary care providers, especially today with the world changed in the past 2 years of the pandemic, are absolutely overwhelmed with primary care health needs of all sorts. And we all see the data coming out all the time about the increase in physical care needs and psychological care needs. We also know that there's been a drastic rise in the incidence and presentation and need for care for eating disorders. So now we know not only that a few years ago the PCPs really drop out of being the treatment team leader, but now they're drowning in work. And we know that the EDTFs, you, us, all of us, are working more than ever to fill the gaps in treatment. And we need more recognized, trained providers across all disciplines. And that's why we're here today. We really want to name it, and hopefully, I always say, if you build it, they will come, that we are hoping that you will have interest in joining us in becoming a recognized eating disorder treatment facilitator, because our primary care providers, whether they're physicians, psychiatrists, PA, nurse practitioners, those PCPs need our help to support them. And most of all, our patients need us to work together to help them. So the EDTFs will be recognized and acknowledged in providing both individual and professional resources to the healthcare providers and the specialists on the team to facilitate and enhance the specificity of care offered, both for the caregivers, the healthcare professionals, to the patients, their families, and their primary caregivers. So we also want to make sure that, you know, I'm sure many people have this, of like, you get the call and you recognize that you need to have your hands on the appropriate materials for the specific care needs of that patient. And you need to have it so you can get it to the right people in a timely fashion. So in developing the EDTF requirements, these are the guidelines that the task force have developed. And as you can see, it's physicians, it's DOs, it's psychologists, master's level therapists, naturopathic doctors and PAs, and the essential dietitians and nurses. If we've left out a profession, please let us know. The long-standing expertise in the field, as you saw in the data collected, people that had over 11 years of experience specialized in the field of eating disorders were the ones doing the lion's share of this work already. So expertise of at least 7 years or 10,000 hours of experience in the field of feeding and eating disorders. The certified eating disorder specialist, so the SEEDS supervisor, dietitian supervisors, and nurses and nurse supervisors in good standing, you know, which are being combined into the SEEDS certification, obviously meet those requirements. Continuing, verified practice, as we said, of at least 10,000 hours of experience in the field. And for individual disciplines, as you see, for the master's level therapists, it's after licensure or their registration. For medical providers, it's after their state issued license. For psychologists, it's the APA accredited internship beginning. And for dietitians, it's after being registered with CDR, and nurses similarly. So we are talking about recognized active professionals in the field. The commitment, very much like maintaining SEED specialization for IDEP, verified attendance in 50 hours in the last 5 years, certificates of completion of the 20 hours in over 2 years, and active commitment requirement of volunteer work, which, you know, even I think of the unrecognized invisible work that EDTFs are already doing. We are providing organizational work and service hours to our community and letters of recommendation. So as you can see, the development of phase 1, we're ready to bring this launch forward. And we've, you know, about a year ago, we really worked actively to develop the application, the decision tree, which are part of our resource materials of helping PCPs understand the decision-making process. And there's a wonderful decision tree rubric that's been developed by Suzanne Dooley-Hass and Therese to help our providers understand the course of action. We have a web page and an approval process, which you'll see in a moment, and bringing these information to the IDEP chapter presidents, detailing the process and the content development that we've been working on over these years. So the application process and the web page are seen here, and on our web page we've been constantly updating as current as this week. Some of the resources are available with this talk, and then if you go to the links page on the IDEP website for the EDTF, you'll find extensive resources. Again, what we want, just like that clip with Dr. Vicki Burkus sharing her excitement with her puppies, we want physicians, primary care providers to be excited and relieved to know that we've made these things available at their fingertips, and we can direct them to these pages where the resources will be readily available and they don't have to go looking for it. I think that's why we get primary care provider dropout, is they simply don't have the time to assemble the resources. And we know as EDTFs, we also are so busy and consumed with the time spent treating our patients and families and collaborating as with the other professionals on the team. We want to make a central site where all this information is available readily. These are the task force members currently. We just borrowed this from the EDTF webpage. It's constantly being updated. But as you can see, this is our core group, including our fearless leader, Catherine, and Therese, as well as Bonnie Harkin, who's the executive director of IADEP, and several other people that have been contributing countless hours to bringing this information and these resources together to you and for you. And I'm always reminded of that quote by Margaret Mead: never underestimate small groups of people in their work to change the world, for indeed those are the only ones that ever have. We may be a small active group working together to bring this forward. We know that there are countless of you out there already doing this work, and we want to give you a place to be recognized and a way to make your work just a little bit easier and a little better defined, so that hopefully as we move on to this next phase, we are rolling out the EDTF application process and ready to accept applications to both the membership of IADEP as well as the AAD membership. We really would love to welcome new members to the task force, and we would also very much like to expand with other partner organizations. As Therese mentioned earlier on, we know that there are other organizations, there are countless other people around the country and around the world who have been seeking to train and empower and build collaborative care. I believe, and as all of you know, and that connections are the powerhouse, that connections heal, and connections are actually the way that we are able to do this work with our patients and their families, and with our collaborative team members. So we are seeking to educate the professionals and bring them up to speed to the EDTF criteria. Many of you are already there. We're ready to approve and certify the EDTF applications and to bring on new task force members and expand this into a network with organizations. We also hope that, and programs for PCPs will also join with us, not only the eating disorder PCP partner organizations, but other primary care organizations, so that we can form community partnerships with healthcare networks across the country and beyond, and make the EDTF connections really the go-to place. And these relationships will be fortified because we're making the process recognized, identified, and easier to access. NSEED and Stripe are already actively working to enhance primary care screening tools. But what we recognize, and I think Therese so eloquently outlined for us, is that physicians have these screening tools. They may have a bit of education and training, but very often they're overwhelmed, because if they have a very complex patient that they're seeing in their office, they still don't have the time and can't immediately put their fingers on the information, the resources, and the treatment team members to assemble the treatment team that complex patient needs. So the aha that started with Therese so many years ago is now our message to our PCPs. Who are you going to call when you have that tough patient? Your EDTF. But what we still recognize is our work in front of us is to effectively deliver a coordinated interdisciplinary standard of care. The EDTF is already the de facto team leader. We know that eating disorders are disorders of isolation and disconnection, and that having a strong team that is connected, that is collaborative, that is knowledgeable and skillful in making sure the patient's needs is essential to treatment, to recovery, to the process that our patients and their families are facing. So our next steps are to recruit you, hopefully, and your colleagues and friends to become EDTFs, to reach out to the physician organizations. I know the ones that I'm familiar with in my work in working collaboratively, especially with primary care physicians and family physicians, and to coordinate, as we've said, with those partner organizations.
I'm Dr. Vicki Burkus, and I'm reaching out to all the primary care physicians in order to tell them that, what? Just there's a patient in room 2 that's hysterical, and all you did was ask him to step on a scale? Well, I think my patient may have an eating disorder. So what do I do next? I call an eating disorder treatment facilitator because this patient needs help now.
So I'd like to thank you all for your interest, your attention, your time joining with us today. Hopefully this has planted some seeds, and you may get the bug to join us and find out more about how to become an EDTF and fill out and complete the application process, join the task force, and help us get the word out so that, you know, we have all been there. We've had someone contact us and say, I understand you're the person. You know it in your communities, like myself in Central Florida, in Texas, and in Oregon, where Catherine and Therese are located as well, and no doubt where you are across the country. We are the go-to person, but now we want to make life easier for all of us and for our healthcare professionals so they know how to find us, and we can help them give our patients the coordinated care that they need that's going to make a difference in their lives and in our communities. And hopefully this will just bridge more and more the gaps in treatment that continue to happen. And we are looking to make this an intricate web of EDTFs across the globe that are helping our patients and helping our healthcare providers. Thank you.
And look for information to come out from IDEP as we start to roll this out. We're going to be doing an information session coming up. So that information will be coming out so you can ask questions and definitely come help us develop it. We're going to start rolling it out in small and develop it as we go. We understand that we're starting small. We'll probably roll out in the IDEP chapters. If you have an interest in joining the committee, helping us develop this and helping be a part of this, send us the information. There'll be links on the IDEP EDTF website, as well as just look for more information to come out. So thank you.
Thank you, Karen, Catherine, and Therese. As a final reminder to those collecting CEs for this session, you must pass the quiz, complete the session evaluation, and finally complete the overall event evaluation within the Context platform. Thank you for attending.